Thanks. So I'm Dave. I'm a medical oncologist. I am entirely focused on immunotherapy trials and particularly prostate cancer. So it's always a pleasure for me to give this talk to you guys. I know this is the second to last talk, so hang in there. Hopefully I will empower you and engage you with some information about immunotherapy. For transparency, these are my disclosures. I have received support from Amgen unrelated to what I'll talk about, but I will be talking about 2 experimental therapies, one from Amgen, one from Johnson & Johnson. So first, you probably have heard about cancer immunotherapy. What is this? It's a broad term. It just refers to any approach where we're trying to use your immune system to do a couple things. One is to recognize your cancer, and then to actually try to kill it. So as you'll see, it's actually a collection of different approaches. This is more of a historical perspective. The point of this is that people have been interested in the concept of immunotherapy for cancer for like more than a century. And it really took a variety of basic understandings of how does your immune system work, as well as experiments and then clinical trials in people, before more recently there have been some approved immunotherapies for prostate cancer. The first being Sipuleucel-T or Provenge, the second being PD-1 blockade. These all happened in the last decade or two, and there are even more to come, but it's a culmination of a lot of effort. So just to give you some language to talk about this, what is your immune system? This is a distributed system, so it's not like an organ in your body. In fact, your immune system is comprised of cells that are circulating and patrolling your whole body, mainly to fight off infection. So there are all these specialized cell types that are in the immune system, and I want to focus on 2. One is called a dendritic cell because it looks like, I guess, a tree or something like that. But what a dendritic cell does is it kind of sops up these targets on your tumor called antigens, and it's kind of like the conductor, because then what the dendritic cell does is it actually talks to an immune cell called a T cell. And believe it or not, there are T cells that can recognize targets on your tumor. So it's really trying to educate them and to try to activate them to try to actually attack the tumor. I think another key insight is that, so I talked about dendritic cells and T cells, but there's kind of a 3-way dance where these cells also interact with your cancer or your tumor, and I think this has been increasingly appreciated. So there's this whole cycle that occurs, kind of starting at the lower left. What happens in this kind of intricate dance is that your tumor cells are continuously dying as they turn over. When they do that, they release these targets called antigens. And then first, those dendritic cells I was talking about, they actually take up the antigens. They then do something called present those antigens. So they interact with your T cells and they try to activate the T cells that could recognize those. Once they actually turn on those T cells, the T cells have to actually make it back into your tumor, where they will then recognize the tumor and then kill the tumor, and then the cycle begins again. So I'm giving you this for context, but also because it's important to put the therapies in this framework, because the therapies, the immunotherapies, each act on different parts of this. So Provenge, which I'll talk about first, is a vaccine. It works on enhancing antigen presentation and what we call priming or activation of those T cells. Later on at the killing stage, this is where PD-1 blockade, called a checkpoint inhibitor, really kicks in. And then finally, there are these newer kids on the block called T-cell engagers, which I'll talk about at the end. These are still experimental, but they actually try to bypass a lot of steps in this, where they're just trying to directly force your T cells to recognize your tumor. So first, Provenge. So this has the mouthful name of Sipuleucel-T, as I said. It's a cancer vaccine. Some very interesting properties. This is actually a living cellular immunotherapy. So these are living cells that are made from your own immune cells. And basically they're taken out of your bloodstream. And in a laboratory, in a dish, they basically make a vaccine which stimulates your own T and B cells to target a tumor antigen on the prostate tumor. Some trials were done in the 2010s, and it helped men live longer over a placebo, and hence has been FDA approved since then for castrate-resistant prostate cancer. Typically, we give this earlier in CRPC to men who don't have symptoms. as I mentioned, is you collect the T cells and actually the dendritic cells, and then you infuse it over 3 sessions. Generally pretty well tolerated with flu-like symptoms. Unfortunately, it does not actually slow the time to PSA progression, so if folks in this audience have received it, they know this. Many of us, including us at UCSF, are working on improved vaccine, like next generation vaccine strategies, but that is still not ready for prime time. So the second category of approved immunotherapies are called immune checkpoint inhibitors. So these are drugs that block something called an immune checkpoint. So what is an immune checkpoint? So these are actually targets that evolved to regulate and control the function of your immune system. Because why was your immune system evolved? It wasn't to fight cancer, it was actually to fight off infections, right? So you need to activate your immune system to get rid of those viruses and so on. But at the same time, you need these immune checkpoints, which kind of pump the brakes to make sure you don't have too much activation, because then those immune cells could start to attack your body and cause what's called autoimmunity. So that's an immune checkpoint, and PD-1 is an immune checkpoint. So PD-1 blockade or anti-PD-1 is a drug that blocks this checkpoint and takes the brakes off. So it lets these T cells, which believe it or not, are already able to recognize the tumor. It takes off the brakes and lets them do their thing. This applies mainly to men with something called microsatellite instability, or MSI, and I apologize for all the terminology. So in these tumors, the tumor is not able to fix its own genetic blueprint or DNA. This is typically less than 10% of patients. But if you have the signature, it really kind of shows or predicts that your immune system can really respond to PD-1 blockade. So therefore, PD-1 blockers such as Keytruda or pembrolizumab are approved for any prostate tumor that is MSI high, or, I won't get into this, tumors that have what's called high mutational burden. This does generally not work for other prostate patients, and this has been proven in very large clinical trials. A brief word about this, because I think we're very attuned to quality of life. These drugs are not perfect. They can cause those T cells to go awry and cause autoimmune side effects. This typically affects less than a quarter of patients. We don't know who's going to get these problems ahead of time, unfortunately. A lot of times, the T cells will attack the skin, causing a rash, or your thyroid gland, but more work to be done. So finally, last 2 slides. I'm focusing on immunotherapies that are soon, I think, hopefully to impact your care. And there's been a lot of progress in recent years. What that means is that this is a drug that kind of works like glue, so it actually sticks your T cells directly to your prostate tumor. So in some ways, this is trying to bypass the whole thing I was talking about where dendritic cells talk to T cells. This is kind of forcing the issue with this drug. This particular one is from Amgen, is called xaluritamig, again, a mouthful. In early testing of pre-treated CRPC patients who had had prior chemotherapy and other therapies, almost half of men had a lasting response in their PSA, which was durable. There are side effects. Some are transient or are temporary from immune activation, like fevers and low blood pressure. However, with ongoing treatment, there are men who have significant issues with their muscles, whether it's just pain or weakness that requires steroids to kind of counteract the immune system. So this is a real issue. The other issue from quality of life is that these are frequent infusions every week or 2 without breaks. So that is definitely an impact. But this is currently in multiple international phase 3 trials right now. Last slide is this other T-cell engager called pasritamig, different target from xaluritamig. Again, in early phase trials, up to 1/3 of castrate-resistant patients had a lasting PSA response. How is this differentiated? Early data, this is not complete, but the immune side effects may be milder. They don't have the muscle issues. There's less of the immune activation. Also, the dosing is less frequent. Like early on, you get it weekly, but then it actually spaces out to up to every 6 weeks. And again, there are multiple phase 3 trials going on, which is why I'm talking about it. So that's it. We'll have time for questions at the end, but now there are already several approved immunotherapies which can last The ones that are approved are either like tailored to the patient, like Provenge, or for select groups of prostate patients, like pembrolizumab for that MSI high. But the T-cell engagers are coming. They're being tested right now. These are unselected patients, but they are intense. They can have side effects. And in all of these, I think the immune system can cause side effects as well. So just some things to know. With that, I'll conclude, and thank you very much.